Right ventricular dysfunction is a clinical and hemodynamic syndrome resulting from impaired right ventricular filling or ejection, often leading to systemic venous congestion and low cardiac output. Contemporary management focuses on a physiology-oriented approach that balances preload optimization, afterload reduction, that is of the right ventricle, and enhancement of myocardial contractility. Diagnosis of right ventricular dysfunction has transitioned from simple visual estimation to quantitative multimodality imaging and bedside assessment. First-line imaging is still echocardiography. It remains the primary diagnostic tool due to its accessibility and comprehensive hemodynamic data. Conventional parameters are tricuspid annular plane systolic excursion TAPSE, fractional area change, and Doppler-derived S prime wave for assessing longitudinal and global function. Speckle tracking echocardiography. Right ventricular free wall longitudinal strain is more sensitive than right ventricular ejection fraction or TAPSE for detecting subclinical dysfunction and predicting clinical outcomes. 3D echocardiography provides a more accurate quantification of right ventricular volumes and ejection fraction without the geometric assumptions required for 2D imaging. Cardiac magnetic resonance imaging is the gold standard for quantifying right ventricular mass, volumes, and right ventricular ejection fraction. It is particularly valuable for identifying infiltrative diseases like amyloidosis and tissue characterization. Point-of-care ultrasound POCUS gives rapid bedside assessment of the inferior vena cava and lung B-lines indicating congestion and allows for real-time monitoring of therapeutic response and volume status. Therapeutic strategies are dictated by the chronicity of the failure and the underlying etiology, specifically focusing on RV to PA coupling. Management of acute right ventricular failure aims to restore systemic perfusion and prevent a downward spiral of ischemia and worsening afterload. Preload optimization. Judicious fluid management is critical. While volume resuscitation is indicated in hypovolemia, excessive fluids in a dilated RV can cause ventricular interdependence, where the interventricular septum shifts leftward, reducing left ventricular filling. Reducing pulmonary vascular resistance is essential. Options include nitric oxide or prostacyclins. Inotropic support. Dobutamine or milrinone may be used to enhance contractility, though care must be taken to avoid systemic hypotension. Afterload reduction. In acute pulmonary embolism or pulmonary arterial hypertension, reducing pulmonary vascular resistance is essential. Options include nitric oxide or prostacyclins. Inotropic support. Dobutamine or milrinone may be used to enhance contractility, though care must be taken to avoid systemic hypotension. Chronic management and emerging therapies. Guideline-directed medical therapy. While traditionally focused on the left heart, recent evidence supports the use of sodium glucose cotransporter 2 inhibitors, that is the SGLT2 inhibitors, and mineralocorticoid receptor antagonists for overall heart failure management, which may indirectly benefit right ventricular function through improved left ventricular hemodynamics. Advanced PAH therapies. Novel agents like Sotatercept, an Activin signaling inhibitor, have shown significant promise in recent trials for reducing pulmonary vascular resistance and improving RV to PA coupling in pulmonary arterial hypertension. Mechanical circulatory support for refractory right ventricular failure, temporary right ventricular assist devices or VADs, or extracorporeal membrane oxygenation ECMO are utilized as bridge to recovery or transplantation. Interventional strategies: valvular correction, transcatheter edge-to-edge repair for severe tricuspid regurgitation is increasingly used to reduce chronic volume overload on the right ventricle. The pivotal Phase 3 STELLAR trial was the foundation for the FDA's approval of Sotatercept on March 26, 2024. The study demonstrated that adding Sotatercept to background therapy significantly improved 6-minute walk distance and reduced the risk of death or clinical worsening. Zenith trial, presented and published in early 2025, specifically targeted high-risk pulmonary arterial hypertension patients, those on maximal therapy with a high mortality risk. The trial was stopped early due to overwhelming efficacy. Finally, a short note on Sotatercept, the first FDA-approved Activin A receptor 2A inhibitor. As mentioned, Sotatercept has been shown to improve 6-minute walk distance in patients with pulmonary arterial hypertension at 24 weeks. More studies are needed to assess the mortality benefit. Currently, the limitations are high cost and unknown long-term effects. Adverse effects noted in the trials were epistaxis, telangiectasia, increased hemoglobin, hematocrit, red blood cell levels, and dizziness compared to placebo.